where did the passion come from for neurodiversity and wanting to okay, champion it and delve into it? Where did that start? What's the story of that?
Okay, so that's a good one. So I've always known that some of my earliest memories are around not fitting in
Okay.
and not really knowing why. Um, Feeling like other people's brains don't work the way mine does. Um, other people are not seeing the world the way that I see it. And I remember being conscious of that from a very young age and being very confused by this, quite upset by this, feeling very lonely and isolated a lot of the time, going through really difficult patch in my teenage years. And then when I got to university, my first degree was maths, and all of a sudden, I was surrounded by people who felt much more like um, uh, it was almost like coming home. It was,
Ah,
oh, here's a bunch of people who understand me, who
yeah.
get me, um, and I didn't really think that much more about it. Stuff happened. I then went on did a PhD. I I realised that um, I got involved in combat sports
Yeah.
along the way. I found martial arts when I was a teenager. Got really obsessed with it. Um, got got very into that. And by the time I was doing my PhD, um, I discovered the world of mixed martial arts.
Yeah.
And at that point, I kind of realised that I didn't get on with being sat in an office. They just didn't work for my brain.
Okay.
Um, so I went off to punch people in the face for a living instead. Perhaps was a bit of a clue
Yeah.
that there's something a bit weird going on here, because not that many people take that particular career trajectory from a maths PhD.
Hmm.
Anyway, it was actually the MMA that got me into MSK healthcare. So I obviously encountered a few injuries along the way.
Yeah.
Got very interested in injury rehab, injury recovery. Found it was really hard to get people who actually understood the sport that I did, as well as being able to give good advice on injuries. So ended up reading around it a bit. Eventually ended up going back to university, and that's when I decided I was going to be an osteopath,
Yeah.
which is where I still am now. Um, a few side quests along the way. Um, so that at that point, I still knew that I didn't really fit in, and I didn't have a particularly good explanation for why. There were certain things that I was struggling with. Struggled a lot around mental health and anxiety, and found some things really difficult around just regular, you know, work life, um, uh, raising a small child. Um,
Yeah.
Lots of that was really challenging, and um, it was actually after COVID when there are a couple of things that I had going on that um, led to quite a serious burnout, and I was in a reasonably bad way at that point. I think having a very bad mental health patch, and one thing led to another, and I ended up um, reading some things that made me think again about um, neurodivergence, and in particular around women who've been had a late with autism.
Mm.
And all of a sudden, some of these pieces started falling into place. And it's like, oh my God, that sounds so familiar. And in the end, I ended up having an assessment and getting a diagnosis. And for me, actually, it was really helpful because all of a sudden I had this explanation for a lot of things that I'd found difficult and I'd struggled with.
Yeah.
Um, but also it tied in with some of the things that I think my brain does really well. And I think it's one of those things where it's not about um, good or bad necessarily. I know that there are lots of different presentations and other people may experience this differently, so I don't want to speak for anyone else. But certainly in my case, it felt like there are some things that my brain does quite naturally that other people don't necessarily. But equally, there are things that other people think are really obvious that I struggle with.
Yeah.
And it is absolutely the two go hand in hand. And I think making sense of that and spending a bit of time thinking about what that meant and how I could arrange what I do and arrange my life a little bit differently in order to play to my strengths and to take the pressure off some of the areas where I find things more difficult. And that's really helped me actually. It's helped definitely with home life, but also with work as well. I think it's helped me to make the most of um, the things that I do well, and I think that's been really helpful.
Because you were saying about later in females, it's correct me if I'm wrong, um, but it's been the case, right, that neurodiversity of whatever part of the spectrum it is usually diagnosed later in females. Is that right?
Yeah, so there's this whole thing about I think certainly autism in particular and ADHD
Mm.
are more tend to be more easily recognised in boys and white boys in particular. And again, I think a lot of that is to do with how those diagnostic criteria were set up, because a
Mm.
lot of it was around looking you tend to find what you're looking for. Right. So if
Yeah.
you think that a particular condition is rare in a particular group of people, it will tend to end up being diagnosed less often in that group. So it becomes self-fulfilling.
Mm.
And this is definitely the way that things went with women and autism. Actually, I think certainly when I was a child, maybe slightly less so now. I think I've got better at masking when I've got older. Um, Although it's funny because I I thought when I was diagnosed that everyone I knew was going to go, you can't possibly be autistic. That's absolutely not what happened.
No.
Everyone kind of looked at me and went, yeah, we kind of knew that. Um, is this news to you? Um, so yeah, perhaps I don't mask as well as I thought I did, but certainly when I was younger, I think I was quite obviously autistic in hindsight. I think I
Mm.
was the nerdy kid who found social communication really difficult.
Yeah.
I definitely didn't read the room. It's something that I'm not perhaps brilliant at now, but I've worked at it really hard, and I think
Yeah.
that means that I tend to do it certainly better than I did then. But um, but yeah, so I think in hindsight, if that was now rather than um, in the 80s and 90s, I think maybe it would have been spotted, but
Yeah.
it wasn't.
I was going to
So
ask, that was my next
yeah,
question was, do you think if you'd have been that age now, because obviously awareness has drastically increased compared to especially those times, especially post COVID as well. Um, you were saying about the criteria earlier.
mm.
Um, do you see them changing or tightening, if that's the best way to use?
So I think the criteria have evolved,
Okay.
and there has been more awareness of the continuum of ways that this can present, rather than it just being quite a specific presentation.
Yeah.
Um, I don't think we're there yet. I think we've got some way to go before we understand this fully. I think there are lots of people who have some, let's say, neurodivergent traits who maybe
Mm.
don't match it up to any of the diagnostic criteria at the moment, but maybe still have some similar challenges because, again, I think a lot of this depends on those individual presentations, those individual traits. Every
Mm.
neurodivergent person is different,
Mm.
um, so it can be hard to generalize across neurodivergence as a whole.
Yeah.
Um, and I think things have definitely evolved, and hopefully will continue to do so.
Okay. When I was a student back in the day, I remember my peds educator said to me, "We're all a little bit something."
Mm,
Because I remember you said I was listening to the episode you did with Matt Phillips earlier in the year,
mm,
and you said about neurotypical. One of the things I want
mm.
to ask you is anyone neurotypical, or are we all a little bit something?
So I think this is, as I say, there are no average people. There are no
Yeah,
average people. Everyone is unique and special in their own individual way. I think when we talk about neurodivergence, what we're generally getting at is there are people who sit sufficiently far outside of what we societally regard as the norm
yeah,
that that causes them problems. And some of those problems may be because they can't do things that they want to do. Some of them are because they can't do things that society expects them to do.
mm,
Um, and I think that creates a lot of issues. I mean, the analogy I give is, there are some things that I can do relatively easily that a lot of people find difficult.
mm,
If it was expected, if everyone expected people's brains to work like mine, if we were in a society where you were expected to be able to go and do some of the things that I've done,
yeah,
there are a lot of people who'd be quite sad quite quickly,
yeah, yeah,
because again, when you're being expected to do things that you, for whatever reason, find particularly challenging, or you find particularly go against the way that um, you naturally, you know, process the world. I think that's where a lot of those problems come from. So it comes from down to what we're being expected to do. And when you think about it, we often create environments that work perhaps for the majority of people who are within a given radius of what we regard as normal,
yeah.
but may not work for people who are outliers. And at that point, we don't think that those people have the problem, but actually is the problem that we've created environments that try to put people into boxes they won't fit into.
Yeah, yeah.
I think an analogy that I like to it's like chairs. We've got people of all different sizes, and very few people are exactly an average height. Everyone is maybe slightly taller, slightly smaller. They might vary in terms of their their weight, their different dimensions, how their their body is. Um, Chairs are designed for your average person, and if you're sufficiently close to that average, you'll probably get on all right with a typical chair.
Yeah.
But there are people we know don't. So
Mm,
if you're particularly large, particularly small, particularly heavy, um, you might have problems with that. And I think that's where the issues arise, is when people sort of fall sufficiently far away from that norm that they can't contort themselves into that box that they're expected to fill. And I think that is something that actually, I think some of the boxes that we try to put people into with our in society, I'm thinking particularly of education system, the
yeah.
healthcare system, um, employment. A lot of those boxes seem to be becoming increasingly narrow, and I think that's one of the reasons why a lot of people are struggling with it.
Mm. Because they don't fit a conventional box. Do you think if I wonder if you said about environment and society, as society changes as it does over time and how life is, will the boxes change? As in, with how AI is coming in and how we've, changed in the future, will what we consider normal, that some people are considered normal at the moment, will they then be considered not normal because they won't fit into the new boxes, if that makes sense?
Things do change over time, and it will be interesting to see how they change. Um, I worry that we're expecting people to be more to conform more and more to a narrow conception uh, of how humans behave, and I think
Yeah.
I have a long rant about this.
Go on then.
That's Um, I mean, I think that we have a lot of systems nowadays that are being run by people who understand a lot about managing widgets. And, they
Okay.
might come from a manufacturing background
Oh
or,
yeah, yeah.
you know, and they try to apply those same methodologies to systems involving people.
Mm,
And I don't think that works very well because people are not widgets.
mm,
And the things that work when you're managing widgets don't necessarily work when you're, for example, providing healthcare.
yeah.
And I think that's the problem with a lot of where we are with healthcare at the moment. And again, I have an interesting perspective on this because I sit a little bit outside a lot of those systems.
Mm,
I am a big fan of and a big believer in the NHS. And actually, one of the big regrets in my career is that I haven't done any NHS work. I think partly that's because a lot of the time they're not that keen on employing osteopaths, and
mm,
partly it's because I think I would really struggle to fit into the right box. Again, I think I'm not sure that there is space in the NHS for clinicians whose brains work like mine.
mm,
Um, but that's another question. But I think I see because of that, I see a lot of people who've really struggled with those systems who end up coming to see me because they haven't fitted into those boxes.
mm.
And as a result, I think I do see a lot of neurodivergent people in my practice. Um, so partly because I think we have ways of smelling each other. I think we know how to find each other.
Yeah,
Um, and a lot of neurodivergent people have co-occurring MSK health problems and conditions
yeah,
for other reasons, which I'm sure we'll come on to.
yeah, yeah.
So I think there's a few things there, but I do see a lot of neurodivergent people, and it's made me think a lot about the way that the way that our systems often fail people.
Yeah, as you say, because our systems are set up to fit the majority, right? The box, so to speak. And if you don't fit in the box, I mean, if I give you a simple example, you said this to Matt. You had the person who came in who was neurodiverse who said their shoulder feels odd,
Yes.
right? It wasn't
Yeah.
painful. And, for a classic system, odd isn't a symptom, so to speak.
Problem then. You don't have pain. It's not a problem. Carry
No.
on. And yet, when we really sort of dug into it and broke it down, and I had to spend a fair bit of time playing around with different movements, different positions. I think it turned out to be a relatively straightforward musculoskeletal diagnosis, um, but that person was experiencing that and communicating that in a way which was atypical, and therefore I think would very likely not have been recognised in a lot of places. So I think in a lot of ways, um, the way that we do medicine, the way that we've been able to do a lot of the research that we have, has enabled us to do some amazing things. I think one of the limitations is that our methodologies rely on um, being able to pick out how things work for a typical person.
Yeah.
And again, it's very hard to sort of see how would we do some of this if we didn't do that? How would we? How can you do that without generalising to some extent, at least? But the problem with that is when you've got people who are outliers who don't experience things in the same way as the majority, who
Mm.
may process those sensory signals very differently, who may describe them very differently. Um, it's very hard then to recognise what's going on. And even with the best will in the world, and I have the luxury of having a lot more time
Yeah.
than many clinicians are going to have for these appointments. Um, but even then, when somebody comes in and they are describing things in a way that is quite atypical, I know that that is going to be that's going to be more of a challenge to figure out. So I'm not sure that there are any easy answers to that, but I think being aware that that's a problem and being aware that there are people who will have important diagnoses being missed because they didn't describe them in a typical way. I think that's an important message that not enough people are aware of.
And also, if that person's turned up to you, to seek help, then it must be enough of a problem for them to want to do that, essentially.
Yes.
If it was
Yeah.
just a bit odd and annoying and it wasn't a problem, they wouldn't be sat there in the first place.
Yeah. And I think something that I see quite a lot, and again, I hear this from a lot of people who end up at my clinic. They've often seen a few people beforehand, and they often find that their symptoms might have been dismissed as being. I Very few people actually say it's all in your head. It's funny that the person comes away with the message that they're somehow imagining it, they're making it up. It's to do with their stress, their anxiety. It's not a real physical problem. That's the message that they've internalized from those consultations. And actually, that can be really distressing for them. So, a lot of people I see, I think, have been, have had, I mean, in some cases, quite traumatic experiences with some of the healthcare systems that they've been involved in. And that's particularly true for people with chronic pain, with chronic conditions. I know we're going to talk about hypermobility and EDS and some of the crossover there. But I think a lot of those people, when I see them, you can tell that they've got a real distrust of healthcare professionals from a lot of those interactions that they've had. And I get really upset and quite angry about that sometimes. I think it's not necessarily the fault of the profession, because again, I understand that if you're working in a very busy, high pressure environment, it's really difficult to give some of those interactions the time that they need. But at the same time, I see the impact that it has. And I think one of the things that I'm seeing is there's been a lot of talk about pain science. We like to talk about, pain is what people are processing. And alongside that, there's the whole pain neuroscience education piece, which again, I think has its place. And I think there is a role for that. I think when you take an overly simplistic interpretation of that, which I do see from some clinicians, I think it's very easy for people to interpret that as, oh, they said it was all in my head. And they said I didn't have a real problem. But also, I think it becomes a bit of a crutch for clinicians sometimes. I think it's all too easy to reach for that when we don't really understand what's going on. And I mean, bodies are complex, and medicine's complex, and healthcare is really difficult, and good diagnosis is really difficult. And I think it's very easy when you're under pressure, somebody's in front of you looking for answers and expecting answers because you're the expert, and you don't really understand what's going on, to reach for that as an explanation. And that is definitely something that I see, and I see sort of the outcome of that and the other end. I'm thinking in particular of a case of a woman who had absolutely barn door rheumatoid arthritis. It was the most obvious case of rheumatoid arthritis I have ever seen. It's all of the classic symptoms. Came into me, and she was really upset because she'd waited quite a long time to see a rheumatologist that a GP had referred her to. And the rheumatologist had asked some questions, and in the end, it basically said, I think it's all in your head.
Oh, in literally those words, or in a roundabout way?
Words, not in those words, but that was what the patient communicated to me, and that's what she heard. I think she talked a bit. I think my understanding is that the rheumatologist talked a little bit about how you seem very depressed and very anxious, and how anxiety and depression can influence, you can cause pain. And she gave her this big spiel about, you know, how depression can be a cause of symptoms. And she went to work basically with this idea that, you know, because she became a bit tearful and a bit upset during this consultation, the rheumatologist's impression was actually this is all being caused by your mental health.
Okay.
This woman, as it happens, was autistic ADHD. And again, I think there are maybe reasons why that consultation was particularly hard for her, perhaps why she became frustrated, why she was presenting as quite anxious and depressed in that consultation, and maybe why she wasn't able to give some of the clear answers that the rheumatologist was looking for. But for whatever reason, that was what she went away with. And anyway, she came to see me, and we went through it, and that really sounds like it's rheumatoid arthritis. Anyway, as I mentioned to you earlier, I was learning to ultrasound scan at the time.
Oh yeah.
So this was just coming towards the end of my course, and I sort of said, okay, let's just see. And scanned her hand, and it's like, that definitely looks inflammatory. Let me get you a second opinion. So talked her through that. Put together the scans, and rheumatologist she saw looked at the scans, looked at her, and yeah, it's obviously rheumatoid arthritis. And I think, we could tell this as a story of, okay, well, one rheumatologist missed something. I'm sure this happens all the time. They're busy people, they've got lots of people to see. But I think there is a more systemic thing here, which is, I think that very often lots and lots of people who are neurodivergent, autistic, ADHD, dyspraxic, dyslexic, all of the other, various plethora of neurodivergencies, we do very often have a common thread of experiences of having things dismissed by healthcare professionals. And I've had this as well in I've had various injuries, which again, in hindsight, were really obvious. And I've had people say, that hand can't be broken because you're not in enough pain. And it's like, well, reasonably sure I am, actually. But for whatever reason, that wasn't coming across. And my words weren't enough. Because they were looking at me, and my body language and my face didn't match up with what they were expecting to see for somebody with a broken hand. And I wasn't presenting in that typical way. So it was easier for them to say, no, I don't think it is. And again, how often do you hear this from colleagues, right? When they say, oh, they said it was a 9 out of 10 pain, but they didn't look like it. I think the impression that people sometimes get that, oh, they must have been exaggerating, or they must have been, somehow they're just oversensitive, rather than actually maybe they are in that much pain, maybe they're just not displaying it typically. And that's definitely something that I've become aware of over the years, is that my face does not always say what I think it's saying. Or at least people don't read it as saying what I think it's saying, which then puts a lot of pressure on neurodivergent people. Once you become aware of this, that idea that I have to go in and I have to present in a way that is typical, I have to perform pain correctly, otherwise my symptoms are not going to be taken seriously. And actually that can be life-threatening, right? I mean, a few years ago I had a major health incident. I had a large abscess, and again, I eventually turned up at A&E once I figured out that this was really something that was not right. Again, it sometimes takes me a little while for the message to get through, that something was going on. But by the time I turned up, I was not really able to stand up for very, very well. I was kind of feeling very wobbly and lightheaded, and again, the people I spoke to were very, come on, you'll be all right, you'll be all right. Just, keep putting one foot in front of the other, and just passed out. And it was like, it collapsed on the floor. And again, whether that's because my body language wasn't adding up with the way that I was feeling, whether there was a disconnect there. Maybe there was. But again, this happens to neurodivergent people a lot. And
Mm.
this is something that I hear over and over and over again. Um, but again, I think that message is something that a lot of health professionals don't always or find hard to hear.
Yes, especially if someone doesn't fit in, as you said earlier, someone doesn't fit in the
Mm.
box. I remember my wife when she was giving birth. Um, midwife said before, when she was in the early stages, oh, you're not established yet. You're not in enough pain. You're not screaming enough.
Mm.
She, as far as I'm aware, not neurodivergent, but will present differently. You know.
And actually, I think this is one of the things about uh, what I'd like to call a neurodivergent affirming approach is that actually, if you apply the same principles that you do when you're thinking about people who are neurodivergent to everyone you see, everyone will have a better experience.
Yeah.
And again, in a sense, this is just the essence of good patient-centered care. This is recognizing that people will present differently, that people will have um, difficulties in different areas. Lots of people have some neurodivergent traits. They may not meet a diagnosis of a particular condition, but they may have some elements of those traits. And if you accommodate those traits, that person will get a better experience of healthcare. They will probably get better outcomes as a result. So, again, the way I tend to look at it in clinic is I don't particularly worry about what diagnoses a person has or doesn't have, because most neurodivergent people don't have a diagnosis.
Mm.
Increasingly people are starting to become aware of these things, but there are a lot of people who are not.
Mm.
I regularly see people in clinic who, we haven't talked about neurodivergence. They haven't mentioned it. I have no reason to think that they think they're neurodivergent. But there are some things that are making me think that they're struggling with something
Yeah.
which might be typical for a neurodivergent person. Now, it's not up to me to diagnose. That's not what I'm there for. But I can recognize that they're having a particular challenge with something. And somewhere I see this a lot is people with a slightly dyspraxic presentation. So they're struggling with movement processing. And I can be aware that that person is having difficulty interpreting my instructions, and I can apply those same adjustments. We don't even necessarily need to talk about it. As again, sometimes I might mention that, sometimes I won't.
Mm.
It very often depends on exactly what the context is, and I think that's a difficult one to weigh up.
Yeah.
But I think the main thing is sort of being aware that this person is having a difficulty here. They're not being deliberately difficult. They're not being a non-compliant patient or a difficult patient or any of the other labels that they might have had stuck on them elsewhere. That person they're struggling with something. And there are things that we can do that will make that experience better for them.
Mm. Talk me through that. What are these things then? I realize it might depend on the individual, but are there some classics?
There are some classics. One of them is your typical flaky patient, right? A patient who maybe turns up late to an appointment. Someone can turn up late to an appointment, that's fine. When somebody persistently turns up late to every appointment and arrives flustered, anxious, apologizing profusely, and this is a pattern. And they may also struggle, for example, to be consistent with doing their exercises. They're having to message you because they can't remember when their appointment was scheduled. There's a few of these things together. So, okay, maybe this isn't just that patient being flaky. Maybe this patient is having some executive function challenges. And actually, I've had a few of these patients where we kind of sat down and talked. Are you finding this difficult? Are you having some challenges with this?
Mm.
It's a difficult one, right? Because when you're running a busy clinic, there's only so much you can do in order to accommodate those patients who are maybe perceived to be making things unnecessarily difficult.
Mm.
But at the same time, I think being aware that it isn't always something that the patient is completely in control of, that there may be a bit more to it. And
Yeah.
sort of doing some thinking around that can then help to sort of reframe that in a different light.
Mm.
And even if it's a case of um, maybe being a little bit more patient with that person, it might be as simple as that. It might be a case of, well, instead of four exercises here, I'm going to give you one. I'm going to give you one thing,
Yeah.
and we're going to talk about when you're going to fit that into your day, and we're going to talk about ways that we can maybe scaffold that to make it a bit more likely that that's going to happen. And rather than me sort of wagging my finger at you because you haven't done your exercises, we're going to talk about how we can address some of the barriers that you might face
Mm.
in doing that. Um, so that's an example. I think there's, depending on exactly what it is that patient is finding difficult. um Again, there's numerous things around that, but the first thing is spotting it, and also recognizing that it isn't something that they're doing deliberately to piss you off. um,
No, no.
um
I guess in a way, the easy thing to be just to ask what will help
hmm,
this be successful, or what will help you get the most out of this, in a way, because they'll know themselves
yeah.
best, right?
And I mean, I will often talk to people about if people come in and they're struggling to do their exercises, for example. I've given them a few things to go away and do. For whatever reason, they're not getting done, and they haven't been getting done for a couple of times now. We might have a conversation around, well, what are the barriers to this, and
Yeah.
why are you finding this difficult? In a, why is this so hard kind of way, because that's a bit leading. But in a genuine kind of, is there anything that we can do that would make this easier for you? And actually, that can be very variable depending on the person, depending on what their lifestyle is, their routine is. And actually, I almost spend more time now thinking about things like that than I do about what particular set of exercises I'm going to give you.
Yeah.
Because, I mean, again, what we know from a lot of evidence is that lots of things can work. The main, or one of the big reasons things don't work is because people aren't doing them consistently. And one of the reasons people don't do things consistently is because they're struggling to organize that around, it's not even necessarily a matter of time. It's not they don't have enough time. It's that there there's a lot of cognitive load going on. And actually, I think this applies to everyone nowadays,
Mm.
because modern life is busy. We've got an awful lot of information to process. There's a lot of things in our heads. And sometimes just trying to keep straight, okay, I'm supposed to be doing this set of things on top of everything else. Um, a lot of people find that hard. So again,
Yeah.
sort of breaking down, well, what are the barriers to this?
Mm.
What can we do to make that easier, to make it more likely that that's actually going to happen? And I've had success with rehab with people, giving them remarkably little, actually. There've been cases where I might just give people one or maybe two things, and just finding ways to help them do that consistently
Yeah.
has made a real difference, much more so than giving them seven different exercises. However perfect that rehab plan might have been,
Yes.
it's never going to be as good as the one thing that they're able to actually do consistently.
Yeah. I agree. I remember seeing someone very recently who had, I can't remember if they had the diagnosis or not. Um, but the problem wasn't that they couldn't do that. Like they had the physical ability to do it,
Mm.
and it might well have helped, but it's the routine, it's the planning,
Yeah.
that bit. That, and
Yeah.
as you said, just one thing rather than worrying
Yeah.
about overloading them with
Yeah.
10,000 things that will get lost.
Start talking about barriers, you get into all sorts of things. I mean, I've got a marvelous occupational therapist who actually I originally ran into her because I was looking for some coaching after my diagnosis,
Oh,
and on how to sort of what kind of accommodations I can make myself as a self-employed person that will make me more effective, basically, and make it easier to manage the way that my brain works.
yeah.
Anyway, sort of one thing led to another, and I've learned an awful lot from her about sort of addressing some of those barriers, and that's something that I've absolutely sort of brought into a lot of the work that I do. So, in fact, we'll talk about sort of what that evolved into later on. But
Yeah.
but but yeah, I found that approach really helpful, and I think I get much better results now. Now that I do that, because again, for a lot of people, it's not about which particular exercises you give them, or are isometrics better than eccentrics, or slow heavy loading, or whatever. Actually, all of these things can work.
Yeah.
The evidence says that lots of this works for some people some of the time, and maybe even for lots of people. But the big thing is, are they actually doing it?
Yeah.
And that's where I think there's a lot more individual variation. That's where a lot of I think the art comes in, is how you're interacting with that person. How do we make this meaningful to you? How do we fit this into your life?
Yeah.
And there's a lot of crossover between this and when we talk about, just good person-centered care,
Yeah.
actually a lot of this is the same.
Yeah.
Um, but again, it's sort of understanding the ways that some of those differences can present. Um,
And I think because always has to be a two-way street. And
mm,
I'm going to make a sweeping assumption here, but average person, if you've got that person in front of you who may have a diagnosis or not of some form of um, diversity, and as you said, there's kind of they're not reacting in the usual way. I remember we saw someone who had the diagnosis, I don't remember what it was, and they afterwards, the person who I happened to have someone observing or listening, they said, "Oh, they didn't seem particularly bought into that." Or didn't
mm,
think, and I was like, "Well, maybe that's just their way of how they are, and that's just maybe they were just thinking about it.
mm,
They maybe not have actually. They may go away and can come back and be completely on board with it. Who
mm.
knows? But we're not. We don't always. All of us. If we've got something in front of us that we think and we're listening to maybe a good idea, we're all going to go, "Oh yeah, yeah," smiling and nodding away. Most get, and
Yeah,
that's it.
I think this is when we talk about some of that interpersonal communication and things like body language and tone of voice,
Mm,
and we're doing a lot of processing behind the scenes of how that person is responding to us. Do they like us? Do they trust us? Are
mm,
they convinced by what we're saying? All of these things are going on all of the time. And if somebody's not responding the way that we're used to people responding, actually that can definitely be a bit of a disconnect.
mm.
And that's something that I think, again, I'm aware of as a clinician sometimes when I work with somebody and I get that, and it's like I'm not getting the feedback here. I'm not, I'm not, how is this going? Is this going
Yeah,
in? Have they
yeah,
are they understanding me? um are they annoyed? What is this? What am I saying? And again, maybe I particularly find it challenging to read people in that way. So
mm,
um, I think I know that I have some particular challenges around some of that. But I'm aware that when you have that disconnect, it is challenging. And I've had this conversation with some of my associates who I mentor, um, and I said to them, actually, sometimes it's really difficult because you want to get that sort of warm fuzzy feeling that you're helping this person and that you're doing good things for them and go away feeling good about that interaction, and
mm,
sometimes you're not going to get that.
no,
And I always say to them, is it a problem with what you did you do the wrong thing, or is this a you problem? Is it that you didn't
mm,
get that warm fuzzy feeling that you wanted out of this?
yeah,
And does that matter? Is that okay? And sometimes you recognize that actually I maybe didn't feel great about that, but I don't think it's because that was a bad interaction. And if again, I'm a big believer in being as transparent as I can with people and just checking in. If I'm not sure about something, or if I if I don't know how something's landing, I'll check in with them.
yeah,
I don't just say, "Oh, is that okay?" Because I'm expecting that most people are conditioned to just say yes if you ask them, "Are you understanding this?" or "Are you happy with that?" People are conditioned to just say yes.
yeah, yeah,
So I
yeah,
spend a lot of time actually trying to make people feel comfortable giving me honest feedback. I think
mm,
that's a thing that we actually need to consciously do, because if we don't do that, people won't give us honest feedback. And then if you're not getting honest feedback, you can't assess whether what you're doing is successful. So you don't know what to do
yeah.
next.
Things like,
Um, so
things
I
like, what are
actually
your
have this
thoughts?
conversation with patients a lot
Mm,
about, I am not necessarily expecting this to all go completely smoothly. I think there will be ups and downs. Some things you might find work well, some things you might find work less well.
Mm.
I want to know what you think, because that's what's going to help me to decide what to do next. And we can talk through what, you know, what that next step is. I need you to be involved in this. This is not just me telling you something and you agreeing to it.
Yeah.
And sometimes you might need to repeat that several times. Again, especially when people, this this isn't unique to neurodivergent people, but it's something that neurodivergent people, I think, get a lot. Is we have there's a lot of social anxiety because we're so used to being misinterpreted and
Mm.
misunderstood, and people taking an instant dislike to us and thinking that we're just being difficult,
Mm.
and um, etc., etc., etc. And I think because of that, there's a real tendency to think, I don't want to annoy this person who is perhaps in a position of power or authority over me, who's
Yeah.
in control of what healthcare I receive.
Mm.
If I annoy them, then maybe I'm not going to get what I need. So I'm just going to go along and I'm going to play nice, and I'm going to, maybe not quite say what I think, because I don't want to risk that. I don't want to risk that relationship. And if I'm not consciously thinking that, I'm subconsciously thinking it, because
Yeah.
it's just there in the background.
Mm.
And also, I don't know whether this is just some deeply embedded um, kind of neurodivergent ancestral memory from, thinking that we're going to be thrown out of the tribe and left behind for the hyenas, or burnt as witches, or whatever it is. But it's that, you know, I can't afford to risk this relationship. So actually unpicking that and getting people to the point where they're prepared to tell you things, even if they think that that is not necessarily what you want to hear,
Yeah.
um, that is not always straightforward.
Mm. Because it sounds like from what you were saying there, may be, I don't know if afraid is the right word, or hesitant or cautious, but
Mm,
to be honest, because
mm.
honesty, they've experienced in the past might have backfired. Uh,
You watched House, right? Did you?
I
I mean,
never, well, no, I
I
know
just
the house
assume
was
that
before
everyone
my
watched
time.
House. I don't know. Maybe I'm
No.
showing my age, but everyone lies. Everyone lies. And the reason for that is not that they're usually it's not because people want to deceive you, because I mean they want you to have the information because that's how you give good healthcare. But there is a lot of stuff around that social conditioning. Um, and again, I don't know whether this is something that um, I'm particularly conscious of because of some of the experiences I've had
Mm.
um, of struggling with communication and struggling to fit in. And I think like there's a lot of neurodivergent women I'm increasingly hearing who have gone through a whole phase of being having a hyperfixation on psychology. And
Oh.
I've got a lot of books at home, and I've got several shelves of books on psychology
Oh,
from when I
really?
went through that phase as a young adult. When I was, and this was me trying to figure things out for myself and figure out, why is this communication thing so hard? Why are relationships so hard? Um,
Mm.
I mean, relationships with a small r. Um, and I think because of that, I spent a lot of time reading around this. And I think I've had people say that I'm quite good at communication with patients. And I think if I am, it's because I spent a lot of time thinking about it and thinking
Ah,
about how to do that well. And I do it very consciously.
yeah.
Um, and I've spent a lot of time practicing. And again, this was absolutely not the way I was when I was a teenager. So I feel like I've come a long way, but it's it wasn't natural. It's not something that comes naturally or easily to me at all.
Mm. Do you think, out of curiosity, we should ask as a routine question? You ask your standard past medical history
Um,
questions.
I think I think you can do. I think there are pros and cons. Um, I I mean, obviously, people who it's good to give people who do have a diagnosis and have an understanding of what that means for them the opportunity to share that.
Mm.
And again, I know being in healthcare settings, sometimes it can feel like everyone's too busy and there's never a good time to mention it. So I think um, that's a good thing. I think it's also being prepared with what are you going to do with the answer to that.
Yeah.
Is if you just ask and kind of note it down and then carry on, um, people might end up then feeling, well, what was the point of that? It's, do you actually know what you're going to do differently? Do you know
Mm.
what how that's going to influence? Are you going to have a conversation about that, or are you just going to brush past it and go on to the next thing? So I think thinking about, if you are going to ask what next, also recognizing that a lot of people don't have a diagnosis,
Mm.
um,
True.
and that might be for lots of reasons. I mean, it's very hard to get a diagnosis now on the NHS, particularly if you're not neurodivergent, ironically enough. I
Really?
often think that actually the ADHD diagnostic process, which I've been through,
Yeah.
um, it almost selects for people who are not particularly severely ADHD.
Oh, right.
Is if you are ADHD, jumping through all the hoops to actually get a diagnosis. Um, I mean, I almost think that the people who are most severely affected are the least likely to actually make it to the end of that process.
Yeah, I'm with you.
So,
Yeah, yeah, yeah. That makes sense.
um, so yes, I mean, I've had a lot of help, and I had a friend of mine who was sort of pushing me to do it, and going, yeah, you need to do this next. But again, had I been left to my own devices, I mean, there's lots of reasons why I might not have gone through that. Um,
Mm.
so so yeah, there are problems there. There's also problems. Again, a lot of people don't necessarily have that awareness. Increasingly people are more aware of it, but there are still a lot of people who are not. Um, and again, when I speak to people about this, and I always have to weigh up the pros and cons of, am I going to mention this? Because again, it's absolutely not my place to make a diagnosis.
Mm.
But if somebody is particularly struggling with something that I think is relevant to their treatment, is it right that I don't mention something which I think may be helpful to them? So again,
Mm.
it's a
Yeah.
tricky one. And sometimes I
Tricky.
will and sometimes I won't. I think it depends on context. It depends on a
Yeah,
lot of factors.
of course. Yeah.
I don't think there's an easy answer to that. But as I say, a lot of people won't necessarily have much awareness of that, or they might have some real misconceptions about what being neurodivergent is or involves. Um, Again,
Mm.
it's yeah, I can think of lots of cases where people um, actually might benefit from a diagnosis,
Mm.
um, but because of their ideas about this, or maybe some of the stigma around it and things like that, that's not a route that they are particularly wanting to go down or
Yeah.
comfortable going down. So there's a lot of things there. And the question is, are we only going to make accommodations for people who have a diagnosis? Because again, arguably in that case, that's one of those things which could potentially entrench health inequality, because
Yeah.
again, we know that people who are relatively more privileged, who have access to money for private diagnosis, who have more education, who have social capital to have people who might be able to help them do some of these things, they're more likely to come in with a diagnosis, whereas people who are relatively disadvantaged are less likely to. Um, so I think it is on us to some extent, be able to recognize when people are having challenges around some of those things, and to be able to accommodate them without necessarily making a big deal of it.
Yeah. Yeah. Well, you said about accommodating, and you talked
Mm,
to Matt about sensors in the room, and like that
mm,
classic one I see with people who are some form of degree of neurodiversity is
mm,
sound.
mm.
And I'll be honest, work in a hospital, so there's going to be bells and whistles, even in an outpatient environment where
Yeah.
there's no, devices around too much. You can still have people doing building work at times,
Yes.
or just people
Yeah,
talking.
yeah, yeah, yeah.
and I can make the room quieter. And I
Mhm.
guess depending on the time of day, you can make it darker. They won't typically want it lighter, will they? Um, you said smells as well tonight, which I'd never thought of. Unless there's been some,
Yeah,
if I'm honest, someone who's particularly smelly in beforehand. Do you think, oh, but I'd never
yes.
thought about smells before.
It's yeah, and I mean, all of these things are interesting, right? Because I think again, people are not always comfortable saying if they're uncomfortable,
Mm,
and I mean, it's a difficult one because, as I say, if you work in a clinic, it can be difficult to control that environment. Again, I have the luxury, the privilege of working in my own clinic, and this is one of the things that actually I think is one of the reasons that I can do what I do and be quite effective
yeah,
is because I'm able to set things up in a way that works for me.
yeah.
But it also means that I'm more able to change things in a way that works for my patients. So
Mm,
I know that some patients, for example, will have the lights a bit dimmer. I know that, again, sound is a tricky one. It's sometimes you can't do
mm,
anything about the ambient sound. I mean, I will sometimes offer people um, noise cancelling headphones.
yeah,
People rarely take me up on that, but again, it's potentially an option for people who are struggling. When it comes to smells, again, sometimes it's just that awareness because I mean, I will occasionally use things like massage gel or massage mats, and sometimes those have sort of a bit of a background scent or something like that. Again, it's sort of just being remembering to ask, kind of going,
yeah.
is this okay? And there are people who go, have you got anything that doesn't smell? And that's fine. Again, it's
Mm,
it it's not difficult. It's just remembering to ask. And I mean, none of us get this right all of the time, and I'm sure that I still have blind spots because there are things which I notice because again, either because people have mentioned them or because they're things that bother me.
mm,
But there may very well be things that I don't notice. And all I can do there is just try to create an environment where people feel safe to mention it if there is something that's bothering them. Um, and again, I think there are things that you can do to try and promote that. Um, it's it's not always straightforward,
no.
and again, it's one of those things that is easier the more time that you have available, which I know is not always a helpful thing.
Well, that it depends on the environment, doesn't it? But I think it goes back to what you were saying earlier about getting feedback along the way and their
Yeah,
thoughts, because that can really
yeah,
guide
yeah,
you.
yeah,
Um, you know, if they're checking, even just checking if they're comfortable or whatever it is,
yeah.
it can just keep things on. It's much better to have the honesty and hopefully they feel able to feedback and then it can
Um,
suit their needs better.
I think sometimes people take a while to get to know you and to feel comfortable,
Mm.
um, and I think what you can do that make people feel more comfortable doing that. I think giving people, you just say, are there any? Do you need any accommodations? If let's say we ask the question, are you neurodivergent? Um, do you have a diagnosis of any of these things? Um, and let's say the person says yes, I'm autistic. Um, if you the next question is, well, do you need any accommodations? Very often people won't necessarily know the answer
Mm,
to that. They
yeah.
won't always know what will help them because they don't. I mean, again, sometimes it's obvious, sometimes it's yeah, the light's really bothering me. Very often it's more subtle things than that. So sometimes giving them suggestions, again, not pick from this menu, uh,
Yeah.
giving them examples of things that you could change, sometimes might help them to then think around that, or just sort of doing some problem solving and troubleshooting together around. That sort of fits in with the way that I like to work with patients anyway. I like to see it as a collaborative effort. I obviously I'm there because I hopefully understand what they're coming in with, and how to the healthcare aspect of it. I always say you're the expert on your body. You're the one who's been living in it
Yeah,
for
yeah.
however many years it is, and you know how you respond much better than I do. So I need you to give me feedback on these things. I need you to tell me how these things, and over time I'll build up a picture of how that particular patient is working, and how they're processing those various inputs, and the both from the environment, but also from anything that we're doing in clinic, or from what we're talking about. Um, but that's again, that's a process. That's not something that we're automatically going to have straight away. And I may need to allow a bit more time for, if I know that somebody is neurodivergent, or I can see that they're struggling. Sometimes the only way to actually effectively accommodate that is to make sure that there is the time there to do that.
And they may need to go away as well, right?
Yeah,
They may need to
yeah,
go away and
yeah.
reflect and think about
I
it.
mean, allowing people processing time, I think, is one of that's a big thing, and I think being aware of that is really useful. So the fact that some people are going to need to go away and think about things. So very often, if somebody's got a decision to make or something like that, I would say, there's a couple of ways we could treat this. We could look at a referral, or we could try some rehab first and see how you get on. And actually, there are pros and cons to both of these. I think you may need some time to process this, so I'm not going to ask you for an answer right away. We're going to talk through it, and then we'll go off, we'll do something else, and then we'll revisit that conversation when you've had time to think about that. And a lot of people who don't necessarily think that they need processing time, and they wouldn't necessarily have said, I need some time to think about it, nevertheless feel better having been given that opportunity. And it's not unique to neurodivergence, but I think a lot of neurodivergent people do particularly benefit from having that bit of processing time.
Yeah, definitely. Well, come on, I'll tell you what, we'll talk about this now because you mentioned it earlier and we were talking about it earlier as well. So everyone's gradually talking more about neurodiversity with hypermobility related conditions. Call it that.
Yeah.
Your thoughts? Why? Why? How? Any thoughts about why this is kind of how these two things have come together, so to speak?
So there is a large co-occurrence
Mm,
between neurodivergence and hypermobility.
yeah.
I don't fully understand why that is.
Mm,
I say fully. I don't understand why that is. I'm not entirely sure that we have a very good explanation. I think there are some theories out there.
yeah.
I think there are some people who've done some really good work on this. I think the name that springs to mind here is Dr. Jennifer Eccles. I know has
Mm.
done a lot in that space. There are other people as well. I don't want to go through a list of names. I'm going to forget people, but there is work being done on that. I think from my point of view, the way I look at it is we're not entirely sure why this is, and hopefully we will at some point. But at the moment, it's having that awareness that people often will have, and it's just like with neurodivergence, where we said people might not qualify for a full diagnosis of a particular condition, but they may still have neurodivergent traits.
Yes.
I think the same is true with hypermobility. And you can have people who actually, if you measure the Bateman score or something like that, pretty low.
Yeah.
When you do sort of the obvious thing, I mean, I know that there are more in-depth assessments available, but I've had people who come in and said, oh yeah, so and so says that I'm not hypermobile because I've got a low Bateman score. And it's like, well, that may be true, but actually looking at how your connective tissues are behaving,
Yeah.
there is definitely something, if you look at the tone, the texture, there is something of a hypermobile feel about it. I mean, that's a very I'm showing my background as an osteopath here, a very subjective way of putting it,
That's right.
but there are patients who you just get that feel about. It's like,
Mm.
actually it feels like this, and often again, this is true with people who are maybe a bit older, who have had there's an element of osteoarthritis going on as well, so those joints are maybe less bendy than they used to be, and we know that people who start off as hypermobile may not score highly later on if you measure them sort of well into adulthood. So I think, as I say, it's always more complicated than that, but I think when you're aware of the fact that there are people who have some elements of hypermobility without necessarily fitting the criteria for a full diagnosis, but still be causing them a problem.
Yes. Yeah.
You know, I think there are times when that can still be symptomatic. So again, it's about matching that up with the overall picture, the presentation. How do we think this is affecting them in particular? So I work with quite a lot of climbers because, again, it's one of my sports. Yeah. So people who they're not particularly hypermobile in most places, but they have hypermobile hands. And actually, I fit into that category a little bit. And I didn't realise that I had hypermobile hands until I was talking to a colleague, a hand specialist physio, and he pointed it out. He said, "You're a bit hypermobile." I was like, I didn't think I was, but actually, in a few ways that are relevant to my particular presentation, I am. So again, it's sort of having that slightly more nuanced reading of it.
Interesting. Yeah, I think you're right. We don't know why yet. So I can ask Jennifer at some point, but yeah, it's a bit of a. But the fact there are so many people with the two combined, there must be something there.
Yes.
Even if, and going back to what you were saying earlier about, you know, people coming into appointments, especially in the case it's going to be younger ages, where it's not obvious from their typical body language or the way they're expressing themselves that there's a problem. And the classic, you hear a lot of people with some degree of hypermobility related issue, that issue went on for years. People told them it wasn't a problem until it became really a problem. Because
I think this is really, again, going back to that thing about neurodivergent people not being believed in appointments. I think, again, we see this with a lot of those sort of overlapping chronic type conditions. So there's hypermobility, you know, there's a lot of the chronic fatigue, fibromyalgia type conditions. Again, I think there's a higher prevalence there. You know, there's a whole raft of things. And again, I think there is often that, and I can see when I talk to, sometimes when I talk to people about some of these, it's the reaction that I sometimes get from people is almost that it's sometimes described as a psychosocial presentation.
Okay, yes, I'm with you.
Psychosomatic,
yeah.
Yellow flags, psychosocial
flags,
presentation.
Yeah.
And I always, that grates when I hear it. So I've my associates know that they're always going to get a lecture on this one. I have form for this, but again, I think I have particular empathy for those kinds of patients, because very often they will present as, you know, maybe quite anxious, quite depressed. There's a lot going on, but of course, I mean, they're in chronic pain. You know, did we first here? You know, how do we know? Are they depressed because they're in chronic pain? Maybe because they're not sleeping. Maybe because, you know, are they anxious because they're in an appointment with that they might have waited a long time for, with a healthcare professional who might not believe them, and they're struggling to communicate their symptoms because, again, I mean, we haven't really talked about those communication differences, I think, in terms of the verbal communication as well. So there's lots of reasons why somebody can present like that, and I think I often see those kinds of patients being dismissed, and sort of you can almost see that sort of sigh. And you go, oh. And again, sometimes it's because actually you know that this is going to be quite tricky. You know, this may not be a straightforward, oh, I'm just going to give you a few exercises, you're going to get better quickly, you're going to go away, and we're both going to feel great. it may not be like that. And again, so this isn't about making me feel good. This isn't about how I go away from that consultation feeling.
Yeah.
This is about, did I do the best for that patient? And I appreciate that some consultations like that are going to be really hard. But again, it's not necessarily the patient's fault that they're hard. It's not their fault that their case is tricky. They are not a difficult patient. They are a patient with some difficult things going on.
Yeah.
So I think actually reframing that is
Mm.
quite important.
You said about that. So the communication styles, I mean, I guess like all this, it's on a spectrum, right? Because there'll be some people with neurodiversity who will give you very frank, to the point answers. And actually,
Mm.
the appointment goes very quickly. We've got to worry about time. And there'll be some people at the other end of the scale who will go on and on and on and on. It probably depends on what part of the spectrum they're on, right?
Presents for them in particular.
Mm.
So I think there's a few things to be aware of when we're asking people questions about things. Firstly, there's the sensory differences. So just at the first level of communicating that person has to process those internal body signals, that the pain processing, the interoception. These are sensors, and they're affected in neurodivergence just the same way that sight, sound, smell. Those other senses can be, proprioception, vestibular sense, all of the things that we don't think of as, they're not one of the five senses, but they're absolutely senses. Those are all processed differently as well. And again, there's some good research that autistic people often have differences in pain processing, not necessarily that they're either more or less sensitive to pain, although they can be either, but it can also be context dependent. It can be some people will feel something, but they don't know what it is. They struggle to identify it. They may have difficulty processing it in certain environments. They may get it confused with other things. There's lots of ways that sort of pain processing can break down. So that's sort of the first step, really. But then the next thing is sort of knowing, well, what do I call that? How do I describe it? What labels am I going to put on this? Yeah. And I think the relationship between neurodivergence and verbal language is often complex. So I think many of us don't necessarily think particularly verbally. And I would say that my natural thought process is not verbal particularly. I always feel like I'm translating into a second language. And I appreciate that I have the privilege of being perceived as relatively articulate, I think. And thank you for the confirmation. I feel validated. And I think that can be helpful sometimes. But at the same time, there are lots of people who find that translation into verbal language much harder. Or there are times that when they can't do it, there are people who will struggle to communicate in certain contexts at certain times with certain people. So I struggle when I'm talking about how I feel. Yeah. And particularly when I'm in a medical appointment, because medical appointments, ironically, for somebody who actually works as a healthcare professional, make me really anxious. So when I'm on the other side of that consultation, I feel super anxious. I can't always tell what my body is telling me. I can't interpret those signals in real time. Yeah. I sometimes say that, my body will send me a postcard that I might get the next day or something. But I won't always be able to decipher it in the moment. And if somebody's asking me questions and I'm trying to give the right answers so they get enough information so that they can, so that I will actually get some healthcare because I know there's something going on here. Yeah. And I'm under pressure to do that because otherwise I'm going to be dismissed and I might not get important healthcare for something that might be quite important. Yeah. So that's all very stressful, and that's going to make me less articulate. And I think one of the hardest things is when somebody who seems quite articulate suddenly becomes less so and becomes very vague or is struggling to answer questions. That very often is then perceived as, oh, you don't have anything really wrong, because if you did, you'd be able to tell me where it hurt.
Yeah.
And that's the way it's often interpreted. And again, going back to the patient I saw who had rheumatoid arthritis, I suspect that was maybe what might have happened in that appointment. So that might have been why that particular clinician found it hard to diagnose. When actually, in a more relaxed setting, actually she was very articulate. And, you know, we were able to dig into all of that. But again, I have the luxury of time.
Yeah.
But yeah, so I think there is that whole thing of, sometimes if you know that somebody is struggling with language, you can allow for it. But if you don't know that, it's harder to allow for it. And sometimes it's hard to know what you're missing. It's hard to see the things that you're not seeing.
Yes.
If you like. So when you have somebody who is struggling like that, who isn't, and they may not come in and say that. They may not say, I might struggle with communication and telling you how I feel because I'm autistic and I'm not always able to interpret the signals my body is sending me. And actually, I'm in a place now where I can say that, and that's really helpful. But this is one of the things that having a diagnosis has given me, is the language to put around that experience, so that it can help other people to understand when I'm struggling. Whereas beforehand, it would have been interpreted as probably something else. So there's that translation into words aspect, and then there's the problem with how that's perceived by the other person, and you know, the fact that the words don't always match up with the body language and that side of things. So even if you're saying, yes, this really hurts, if you don't look like it really hurts, then that person may still miss the fact that, yes, you might have something really wrong here. So yeah, there's a few stumbling blocks there, and as I say, you know, when somebody is struggling with communication, I don't want to be the person who, you know, thinks, oh, it's always this, because again, it can be a whole bunch of things going on there. You know, it might be, especially if you've got somebody, for example, if English is their second language, they might have communication problems. It might be to do with sort of health literacy or education or cultural background, or there can be any number of reasons why somebody may use atypical language to describe what's going on. Again, I mean, when you think that actually, even when we talk about some of the health inequalities facing women, and you know, women are not a minority of the population, but a lot of the time, because our default medical model is based around research that was done in men, a lot of the time women present with symptoms slightly differently, so these aren't always recognized. And you know, we talked about that in, say, diagnosis of autism or ADHD, because those symptoms can present a bit differently. But even in things as simple as a heart attack, you know, we know that there is a difference in how men and women will typically describe those symptoms. And we haven't even got to grips with that yet. So for groups that are even more of a minority, like say autistic people or ADHD people, or you know, people with any of these other conditions, the fact that they may come in with things that are wildly different from the way that a typical person might describe that condition or those symptoms. And again, you know, how do we train healthcare professionals? When we're training people to take a subjective history, we're looking for certain criteria in order to, and that, you know, if we hear certain things, that makes us go down a particular pathway, because this is all based around pattern recognition. That's how what we do works. But again, if we're not even aware that people might be describing these things in different ways, or they might be experiencing them in different ways, then, you know, even when you are aware of all of that, it is still a really difficult problem. And I think there's probably a space for people who are neurodivergent specialist MSK professionals who have experience of working with people to, I mean, again, I think I often end up seeing people, not necessarily with a diagnosis, but because maybe they've had a look at some of the stuff that I've said, or you know, they've looked at our website and they've just got that intuition that I'm somebody who they might happen to feel safe with. And actually,
Mm.
I always think that that is one of the most meaningful compliments that I've ever had is, knowing that somebody feels safe in that environment,
Yeah.
because I know how easy it is for many of us not to. Um,
Mm.
and I think that's, we tend to be drawn towards environments where we get the sense that we're going to be heard, we're going to be listened to.
Yeah.
And that's what I always try to put out there.
Yeah.
I think I hope that as we get better at the awareness thing, and for all that people are talking about it, I think the next step is understanding what to do with some of that information.
Yeah.
And when people are saying these things, what does that mean for how we're interpreting that how we then go about doing what we do? How does that change our process? And I think that's the next thing.
You think that's
And I mean, it's a lot because we already have a difficult job. I think as I say, I I think the longer I'm in practice, the more I realise how hard doing what we do well is.
mm.
And I almost feel like I'm getting further away the more aware that I become. It's because you become aware of all of the many things that you should be doing.
Mm.
Um, but I think again, it's something that can make so much difference
Yeah.
for those people who I think often actually are probably disproportionately represented in some of our clinics.
Yeah. And I think I was going to ask you this at the end anyway, but we got to it right now. You said about the next step is knowing what to do about it, right?
Mm,
And we said about earlier about asking them essentially
mm.
what would help. Is there anything else that you think it would be almost the next steps where this may all be going in the future, so to speak, for helping these people, whether it's an MSK environment or any healthcare environment?
Yeah. And like I say, I mean, I think it's bigger than MSK for
Yeah.
sure. And there are obviously lots of other co-occurring conditions that don't necessarily fit into MSK. It's just happens to be where I am, so it's what I'm focused on right now. But it is something that I'm working on actually. As I say, I've got this fabulous neurodivergent specialist OT who
Mm.
I've worked with for some time now, and we are working on putting together some specific material and a training course for initially for MSK health professionals, but again, hopefully this is going to be broader than that eventually,
Yeah.
in terms of things to think about and ways to practice in a way that is neurodivergence affirming.
Mm.
So it's not, again, it's not just about accessibility, which I would say is sort of our bare minimum.
Yeah.
It's how we practice in a way that is that will genuinely get the best results for that group of people. And actually, I think all of our patients, I think all of our patients, if you're practicing in a neurodivergence affirming way,
Yeah.
everyone benefits.
Yeah.
I think whether you're neurodivergent or not, because everyone is it. If we look at all of those traits that we're looking at when we talk about neurodivergence in terms of sensory processing, communication, executive function, movement, all of those other things, we're all in slightly different places in that space. So we've
Mm.
got this multi-dimensional space, and we're all scattered all over it. We've got little clusters of people, and we've got a diagnosis for this group of people here, and we've got a diagnosis for this group of people over here.
Mm.
But then we might have people sort of way out here, but we don't have a label for that.
No.
Um, but again, I mean, the way I look at it is that labels and words, they're useful because they're handles for concept. They allow us to sort of move that concept around and do things with it and communicate it to other people. But actually, these things exist independent of that, and um, our current understanding of the diagnostic space is not a, a full and complete representation of what's going on there. So I think, again, sort of thinking about people as individuals and sort of how those individual traits affect them as an individual, in the same way that we think about, how somebody's lifestyle affects them, or somebody's, sporting activities, or, somebody's range of movement, or their, various tissue types, or body weight, or, we think about all of these variables all of the time. Again, this is another lot of things to think about alongside that,
Yeah.
which again affects the outcome of those treatments just as much as any of those other things do.
Yeah. Yeah. Yeah.
It's a lot to process. It's again, this is why I'm exhausted when I get to the end of a clinic day, right? Because you've got, I mean, I've got a brain, like I said, likes a lot of detail. I love, I'm a nerd's nerd. I love to dig into this stuff, and but it is a lot to process.
It is. It is. Especially if you're having to do the other things as well, like you said, like worry about your own presentation and your own how you're coming across, so to speak, beyond, I say dare I say the norm, so to speak. We're having to think extra more about that than usual. This course will come out sometime later this year. You said, is that right?
Yeah. I was going to say, as a neurodivergent person, I actually think that this job really suits me. In fact,
Ah.
in hindsight, I can't think of a more perfect job, because people turn up to my very familiar environment that I have structured the way I want it,
Yeah.
and we have a conversation about quite structured conversation, about something that I'm very familiar with and very interested in, and I can hyperfixate at them about that for a fixed length of time, and they're generally quite interested in it too, because it helps them out, and then they pay me money for it, and it's great. I am living the dream, as an autistic person. So yeah, I love this, but the challenges for sure, and I think the communication side of things is something that I have had to work at, and think about and practice quite hard. But like I say, it's a relatively familiar environment. It's a familiar set of topics that we talk about, and it's again, it's a one-on-one conversation, generally speaking. So from that point of view, I think it works really well for me.
Yeah. Well, good. Well, speaking of your
Just an
job,
aside.
so your clinic's in Alton, right? Which is
So
Solihull.
we're Solihull, just south of Birmingham. Oh, I am. You can find us online, altonhealth.com, OLTON. And yeah, that's me. So by all means, get in touch. I would love to talk about this stuff. So if anyone's interested in finding out more, or wants to drop me an email, I'm always happy to have a chat about it.
And you're personally on like Instagram, LinkedIn,
Yeah, so
etc. as
I've
well.
got I've got a personal account. I've got a clinic account, which I'm trying to be better at posting from. I'm not always good at staying up to date with that. So the whole running a clinic side of things, that's something that's one of those things that I have to focus on, and it takes a bit more effort.
Yeah. Especially because that's, yes, if you're running it as well and it's but if it's a job that's suited for you, Rosie, then hopefully it's worth it.
Absolutely, like I say, I love it, and I think, again, from my perspective, I think feeling that I'm making a difference,
Yeah.
is it's great. I don't know whether it's that neurodivergent compulsion to make myself useful, so that if I'm not going to fit in, at least I could be useful. But no, I'm kidding. I think it's something that again works really well for me. I'm running with it.
And you and Mike James, what's the name of the podcast called? Remind me.
Yeah, so we're the everyday athlete.
Everyday Athlete. That's
So
it.
it's a podcast. The idea is that it's aimed at a cross section of people. So bringing together both people who do sport, not necessarily at a high level, but who enjoy it, want to be better at it, um, want the aren't as young as they used to be and want to
Yeah.
keep
Okay.
doing it
Nice.
as they go on. So whether this is just where we found ourselves at the moment, I don't know. It might be a reflection of that, but also with clinicians who treat sports people, and bringing all of those groups together, and coaches who work with sports people as well, and kind of trying to integrate those perspectives, because very often you have sports people on one hand, and then you have clinicians on the other hand, and the clinicians are getting frustrated with the fact that sports people are wanting to be out doing their thing and not necessarily doing exactly the rehab they've been prescribed, or taking the rest that they've been asked to take, and then there's the frustrations that the sports people have with clinicians who don't always understand their sport, or their needs as an athlete. So I think the idea is to try and bring those things together, which hopefully we managed to do.
Good, good. Grand. Now, was there anything about neurodiversity that you wanted to say, or you had written down that we've missed?
Talk about a difficult clinical conversation.
I always ask everyone, and I've realised that I was worried about time, but we can ask it now, absolutely. So I didn't. It's up to you if it's neurodiversity related or not. But talk me through a difficult or one of your hardest clinical conversations.
Yeah, so I can think of several. I can think of several, but I think one that stands out to me, and this was before I had a good understanding of the neurodivergence piece of the puzzle. Um, and it was a client who I'd been seeing for a while, and this was after I moved from Manchester to Solihull, and this was a client who I'd been seeing up in Manchester.
Mm.
And when I left, I tried to find him another clinician. I sort of tried to find him somebody who would get on with. But he insisted on coming down to see me,
Okay.
and he'd travel a long way to come and see me specifically. And again, in hindsight, I had thoughts about why that is, but I think there was this particular occasion when he'd been having a really difficult time,
Mm.
and he'd been involved with mental health services, um, and he'd had a number of diagnoses, including things like borderline personality disorder, and a, a couple of other things. In hindsight, I think he was very obviously autistic,
Mm.
and eventually I did have a conversation with him about that, but he hadn't been diagnosed. And in fact, I think the psychiatry team that he'd been involved with had dismissed that idea when he'd asked about it previously, prior
Oh.
to us talking about any of this. But he was having a very difficult time because of the way that he'd been treated within the healthcare system.
Yeah.
And he had a range of MSK issues that we were looking at, but we got into talking about sort of what was going on in his life, and he started talking about how he'd been having some suicidal thoughts, and some of the things he was saying sounded on the one hand quite paranoid,
Mm.
um, but also I think reflective of the fact that he had some really difficult and um, uh, upsetting experiences, with some of these systems in particular.
Mm.
And I found this so hard because obviously I am not a mental health professional.
Mm.
I have I think, better than average understanding of mental health and mental health conditions. but I am not a trained mental health professional,
Mm.
and I'm aware that the textbook, the right thing to do is to refer this person to appropriate support. However, because of his situation, he absolutely did not want to be referred back to the mental health team,
Mm.
who in fact were causing some of the issues.
Ah.
Um, and he was reluctant to, I asked him about, can I write to your GP? He was very reluctant. Let me do. And I sort of said to him, look, there are people that you can talk to. And she said, where? Where? Um, and increasingly,
Mm.
I mean, this wasn't particularly recently, but I do think that there are patients for whom they're coming in, they're sometimes with mental health conditions, sometimes with other things, for whom I look at them and I go, you know what, I know what the uh, the pathway should be, but actually the services that this person needs are not there, or
Mm.
not accessible.
Yeah.
Um, and I can't fix this, but I don't know where else to send them.
Mm.
And I mean, one, it's terrifying, but also it's heartbreaking for the patients. Um, and what do you say to somebody in that
Yeah.
situation when somebody is telling you that they're feeling suicidal and that they've tried everything, and they literally have, they've tried everything that I can think of, um, and it's like, what do we do with this? But at the same time, the fact that I am somebody that he can come and see and who he
Mm.
feels safe with and who he feels safe to have that conversation with,
Mm.
that's not nothing. And I can only do as much as I can do. Um, but at the same time, I don't want to be the one saying, actually, I can't see you because this is too complicated.
Yeah.
Um, because where else is there? I think, and
True.
I see this a lot where people are sort of they're um, they fall out of services because they're too difficult, they're too complicated, their needs are too, um, and yeah, where do you signpost
Yeah.
them?
It's really tricky.
So I find that really difficult, and that's one of the things that keeps me awake at night. I've said to people, I have a running joke with my husband that sometimes it feels like throwing starfish back into the ocean. I don't know if you know the story about the young boy walking along the
No.
beach,
No. No.
and he's throwing starfish back into the ocean. And this man comes up to him and he goes, "Well, what are you doing? Why are you doing that?" Well, the sun's about to come out, and the starfish are all going to die. And he goes, "Well, but there's miles of beach, and there's thousands of starfish, and you can't possibly make a difference." He goes, "Well, I made a difference to that one."
Mm.
And sometimes that's what this feels like.
Yeah. Well, you can't. Is
But
that you can't help
I
everyone, can you? But never. No one
Yeah,
will ever
yeah,
help
yeah,
everyone.
yeah. But I mean, this is why I keep thinking about, what can we do? And I think, one of the things that I try to do is to get the message out there. I'm hoping to do a bit more in terms of putting some structured learning and
Yeah.
CPD
Yeah.
together around
Yeah.
around that, so hopefully there will be more of us throwing starfish back in the ocean. Hopefully one day we might get to a point where we're not having to do that. So
Yeah.
that's that's the goal. But
So
we'll one step at a time.
we'll see. Well, we'll find out worst later this year, won't we? That'll become available to
So
people.
the organisation that we're we're working under, what we're developing is called
Neuroflect. Okay.
Neuroflect.
Does that
And
stand for
there is
anything?
a web page up there at the moment,
No.
and there will be more coming soon. So watch this space, as they say.
Ooh, excellent. There we go. I can put that in the description. Anything else you want to say that we've missed?
I think we've covered a lot of stuff. I hope that hangs together coherently.
Definitely.
I end up going off down a lot of wormholes, but again, I think
That's
that's
okay.
the way my brain works.
It's fine. Well, I'm just grateful. I'm just grateful that you messaged me last week and they were so quick and spend your hour and a half at least with me tonight to go through this because on the topic it's a topic that's never been covered before.
Gosh, we talked a lot. Yeah, that's gone quickly.
Yeah, thank you very much, Rosie.
Thank you, and thank you for having me on.